This is a senior rehab podcast, the podcast for rehab clinicians that want to better serve older adults.
Welcome to the Senior Rehab Podcast. My name is Nicole Nexon, and I'm coming to you with the state of the SNF. I have two of my co-workers with me, Katie and Christina, and we're going to talk about working as a team with different disciplines. Thank you. You're welcome. Different disciplines, the good, the bad, and whatever else comes
medium.
Up. And the medium. There's a lot of medium, I think, some days. Now, there's a lot of good. All right, first rule, girls, we have to watch our language because I've already sworn in Sue's kitchen once.
Right.
And so.
I was thinking about that. How that's going to be a challenge for me, but I will try my best.
All right. We'll do what we can, Sue.
Sorry.
We'll do what we can. All right, so you guys want to just take a minute to introduce yourselves, and that'd be great.
What should I say? Just what I do?
Who you are and what you do.
I'm Christina. I am a speech therapist. I've been working with Nicole. We've been working together since like 4 years. That was when I started. Yeah, so. Just about. And this is all I've done. This is my only marketable skill.
She's only done geriatrics. This is her only marketable skill.
Yeah, that's all I've done. Aside from internships, but those kind of barely count. I don't know. They count.
And my name is Katie. I'm an occupational therapist, and I've been working with Nicole for 2 years. My only job.
And me for 2 years.
Only marketable skill.
Same.
You never know, guys. Maybe you'll have more marketable skills after this.
Yeah, maybe. Maybe I'll just I'll just do podcasts about any topic. That's what happens.
So this is already going to go well, you can tell. Mm-hmm. Anyway, so first I want to start off by saying, like, we are not all, like, rose-tinted glasses people. We're generally pretty real. Pretty real. So I would say, like, let's get this out of the way. What do you think is, like, the downsides to working in a building with, like, a ton of other people and a ton of other disciplines?
You're looking at me, so I'll say something.
Okay.
I feel like, first off, as the speech therapist, sometimes I'm a little bit of, like, the outlier just from not being in the gym. I'm not in the gym. I'm bedside most of the time. So a lot of I rely on report a lot from other people, which can be good or bad. You know what I mean? It's just kind of, like, different. And then, like, yeah, like, the scheduling thing can be, like, a pain in the butt sometimes because, you know, when you have, like, 6, 7, or 8 patients, it's one thing. And then I might have 8, 9, 10, 12, 13, 14 patients.
Yeah.
Which can be, it's a very tricky Tetris game, and dealing with, you know, just being in the right place at the right time and starting at the right time and ending at the right time it can just add, like, an extra layer of stress aside from, like, managing the patients.
Because you have shorter sessions, right? Like, we tend to have, like, I don't know, 75.
You guys are both the same with that, right? Like, generally?
Sometimes.
Yeah.
It varies. It varies.
But I don't know. What do you think?
But, like, if I have a patient that Nicole has, and I'm wondering when Nicole's going to see her, I turn to my left, and there she is.
Right.
And I say, Nicole, when are you seeing so-and-so? And even if it's like, oh, I'm getting her right now.
You're like, oh, not me then. Cool.
We could at least work it out then. It's not like I would have to run and find her. It's not like...
Yeah. I feel like a lot of times I put the texts in kind of, like, a crappy spot. And I try not to, but I also kind of have to sometimes, where I'm just like, but can you ask them if I can have another 10 minutes? Because, you know, the aide was, like, elbow deep in something up until, like, 10 minutes after I was supposed to start with them. You know, so a lot of it, I think that's the thing, is, like, a lot of it is out of our control.
I agree.
Which is another thing that's kind of unique to, like, the SNF.
Right.
Like, the inpatient setting.
And I was saying, like, you know, you would think that, well, they're always there. The thing with the outpatient is, like, they come, and sometimes they're late, and it is what it is.
But they're there on purpose.
And the thing with the SNF setting is that Yeah, they're there all the time, but that doesn't mean they're always free.
No.
They're in bed, they're sleeping, they don't feel well, they're nauseous, they're on the toilet, they're still on the toilet, they're still on the toilet, they're hungry, they're tired, they don't want to come to the gym.
They already spent 2 hours with you guys and really don't want to see me.
Or they're mad at you because you made them play stupid memory games, and now they don't want to do anything else.
And their family's coming later,
and
so
their family's
obviously
coming
they need to take a nap.
Yes.
My favorite that I've gotten this, there was one, I don't know, the patient basically just lied straight up and said, oh, like my daughter's coming from out of town, so I can't do speech therapy this afternoon. And I was like, great, like I'm not, what am I going to do? Like I'm going to not be like, no, you can't see her. Nobody was coming. She lied. She completely lied. She just didn't want to do speech therapy anymore and didn't want to tell me that. It's like, we can have that conversation. Like, that's a conversation that I have like 20 scripts in my Rolodex of like how to deal with different scenarios and manage that and figure out like, what, is this reflective of a different concern, or did they just decide they hate me? Like, or like what,
Personal.
To anything in between. I can deal with that, but no, she just lied. So it was sometimes people don't want to be in a sniff, and very often people just don't want to be there, and they I don't know. You have to deal with it.
Yeah.
It presents in different ways.
Yeah.
For sure. And it's funny that you say we have each other to talk to and get to each other easy, because, a lot of other therapists on this or in the group that I talk to are in home care. And they talk about how they feel like they're in a silo. Like, that's what they describe it as. Like, it's just me. I'm in a silo. It's hard to interact with our therapist. But what I love about our department is it's huge, first of all. There's a bazillion of us. And second of all, I can always talk to people. If it's another PT to bounce ideas off of, or if it's I can grab Katie and be like, all right, can you help me figure this out from what are they doing? how can I fix it? Or
proof a note for content, so you're not going to say anything stupid.
Yeah. Or I can even say to you, okay, I don't think they're learning this. Can you help me? Even if I don't, sometimes I'll just straight up
I love that.
you.
It makes my job so easy.
Sometimes I'll straight up ask you, can you look at someone for me? They're weird. They're doing something weird. And sometimes I can just say, how do you want me to talk to this person? Yeah. Because that makes my job easier, and it, helps back on you.
And actually, since you started asking me that is one way that I will orient patients to, what speech therapy is. Because, Katie, you probably go through this too, is people don't know what OT is.
Oh, you mean physical therapy?
Yeah, and people don't know what my grandson who's 3 and can't say the R sound. First of all, everyone at home, if your kid can't say the R sound and they're 3, good. They shouldn't be able to. But I'll get, my grandson gets speech therapy. It's okay, well, this is going to be very different from that. But what I started saying to them, which I really got from you, which is, we need to learn about how you learn so we can do a good job talking to you. So we can do a good job explaining things to you in a way that's fair, that you'll understand. And that I got just from the way that you phrase, that you phrase screens to me.
Oh, good. I'm glad. I feel like being able to have you there to bring that, because I know people learn differently, so it's been good
and
to be
that's,
able to talk to you about those things.
And that's layman's terms. When I say that to patients, they get it. Yeah. So it kind of, I don't know,
definitely
gets people
made,
on board.
Yeah, it's definitely made communicating with people easier too. So funny that you mentioned people don't know what speech therapy is or OT. Katie, I'm sure people will say to you, oh, but I've already had my PT today. When you walk into the room, if we get there first.
God. I already went down once.
Yeah.
What are you doing here?
How do you explain to people the difference between PT and OT? Because, we know what the difference between PT and OT is, but they hear occupational therapy. And I've had people say to me, I don't need that. I don't have a job anymore. Yeah, I'm that is not what it is. So what do you say, Katie? What is your answer to this?
Typically, if I'm asked for a quick definition, I say, it's the functional stuff. You get yourself washed, you get yourself dressed, you cook, you clean. And the bottom line is that's great that you're going to PT, and I love it. And if you can walk to the bathroom, all the better. But, you can't walk around the rest of your life naked. You should probably be clean.
And wearing shoes.
And have your shoes on. If you're going to be living alone, you should be able to prepare yourself some food without hurting yourself or not ending up with food.
Poison.
So it's the things between the walking in a way. You get up, you walk, where you going to the bathroom. You need to be able to manage your clothes, manage yourself. You're going to walk yourself to the kitchen. You're going to want to get yourself a snack.
Do you feel like there's, do people care? I mean, my caseload doesn't often carry things over. So, and I don't really, do you feel though, like people who are, haven't had the same cognitive changes that a speech patient might have, did you have to tell them that more than once, or did they get it? Like, do you know what I mean? Do they remember?
They get it better in the context. So they know that
when they're in the session,
when they're in the session,
and when they actually start.
When they're actively like getting themselves dressed and having trouble, that's when
and realizing that it's work.
Like, I cannot put my shoes on right now. That's a problem. That's when they start to get it. Like, I can't stand long enough to brush my teeth at the sink. That's when they're like, you know what? You're right. Maybe I need you.
Yeah.
I know.
Yeah.
That's why I'm here.
Yeah. Huh.
Typically, yeah. Except some really stubborn.
Which is a whole other story.
I can do everything for myself. I don't need you, honey.
Yeah.
I love the honey.
Oh, yeah.
9 times out of 10, I do not want the honey.
I have to say...
Well, the honey is because they don't remember our names. Like, let's be real. They
Sometimes. I don't know. I'm a little...
Sometimes it's sarcastic, and sometimes they just don't know what your name is. And that's cool, because there's a lot of us.
Okay, dear.
I've been gotten an unusually high level of sarcasm from my caseload over these last couple weeks, but they were discharged to home on a diet, so I am better now.
Yeah, because you have COG and diet.
Yeah.
So
yeah, and very often at the same time.
They come and go in waves.
Yeah.
And it's the same way that you have a lot of dysphagia patients or a lot of COG patients, that I feel like I have a lot of people who don't want to do therapy. Or a lot of people
that is super
love therapy.
Yeah.
It's like they come and go in waves.
Yeah.
And it's not always a nice mix of all.
Not wanting to do therapy when you're in a therapy building is really not a good attribute to have.
No. And I feel like it's a little bit of bribery. Like, I know you all laugh that I feed my patients. Like, oh, you see a patient in the gym.
I love when you feed my patients.
Oh, they're sitting there with cookies. It must
have
be
a
Nicole's.
table with coffee and cookies.
When I have a patient who I allow certain things with caregivers, and they have you though, I know they'll get that extra practice I want them to get. So I'm like, this is great.
I am not above bribery.
No. You always bribes too is Gigi. Gigi gives...
She's a good briber. That's where I learned my skills from.
You both bribe with food, yeah.
And Gigi gives the white glove,
she has good treats.
All-star breakfast for her AM people.
She makes people ice cream shakes. She legit sits there and
I've
mixes
never
up
seen that.
Oh, yeah.
There is no length she will not go to.
No, Gigi will do what she has to do.
That's amazing.
To get that agreement. I learned a lot from her.
That's
and it's funny because
I learned all my bribery skills.
I learned all my bribery skills. I learned a lot.
Interdisciplinary teaching.
Yes, because we should clarify. Gigi is a occupational therapist. And
all-around wise human.
all-around wise human. And I don't think there's anyone in our department in any discipline who has not learned something from her.
Even the people who have not met her have learned from her. I started when Gigi was not actually working, but I learned how to put on ACE wraps from a therapist who had learned it from Gigi. So, I had not met her, and when I finally did, maybe a year later, I was like, Gigi, I've learned so much from you. I can't wait to learn some more now that you're actually here. And
I'm sure she was like, oh, stop.
And that brings up a good point. You guys, this is both your first job, right?
Yeah.
And so I started in the SNF, and then I went into outpatient, and then, came back. And one of the things that I really liked, and one of the reasons that I picked the building that I did pick, was because I felt like there were people that I could talk to and bounce ideas off of.
Definitely.
Sue was still a therapist when I was there. And I felt like just meeting her the first time, I was like, this is somebody that I can talk to. And I feel like our department, for all our little quirks and whatever, we all get along enough to the point, and and to the point where we feel like we can have those open conversations with people. And there's nobody that I feel uncomfortable approaching or asking questions. And I feel like that was one of the reasons as a new grad that was really appealing to me.
Well, and I think a lot of it is too is that now that everybody sitting at this table has kind of been there for, we know everybody and we know everybody's ins and outs. So even though talking about interdisciplinary stuff, it's there are things that I know that is a fair ask of Katie that maybe isn't a fair ask of somebody else.
Yeah.
So I will, but it's not, I don't know, it's not annoying though, because it's like,
No,
I just know that
where the line
person.
is.
Yeah. I just know, or I know like, oh, this certain person, like they never like fill in their schedule on the computer. But I know who that is, Nicole. But I know
she's like crawling under the table.
But you're consistent with it. But you're consistent with it, which I appreciate. Because then
it never stays the same.
But you're still
why
flexible
bother?
with it.
But
well,
like
I have to be.
if we both have, if we have a mutual eval or something, I know I can't look at your schedule and see where the hole is because that hole isn't real.
That hole isn't real.
And I can just ask you, and it's not a big deal. And also too, like, although I mean, I feel like it's a lot easier for me to track you guys down because I can just call the gym to track me down. It's like you could be. I mean, I'm usually
check 3 lounges, the dining room, and every single patient room.
Yeah, yeah, exactly. So that's kind of a. It's not a huge challenge. It's also nice, like chair dancing. I know that I will like. People are always in chair dancing, and I'll just catch. People, have you talked about that before? People don't know what that is.
Yeah, no, I talked about it on, we had another episode one time about, cultural norms. And, like, trying to break through that cultural norm that, like, old people shouldn't exercise or that old people, like,
can't dance. I can't tell you how often I will, like, politely but firmly correct people in the hallway when I hear conversations like, oh, are you going to that chair dancing group? No, I'm in a wheelchair. I can't dance. I was like, give it a shot because I bet you can. Like,
just you wait.
Just you wait. I'll see you there. Like, you're gonna prove yourself wrong. It's gonna be great.
And
it's gonna change
like
your life.
and I was saying that I love chair dancing because they have a good time, they get to interact with other people. So yeah, I love chair dancing. And the one other thing that I like about it is that it gives us a chance to talk too. Like. Sometimes when the groups are small, like a lot of times us therapists are like right in there, filling out the group and dancing with them. And sometimes when the room gets crowded, a lot of times we end up like kind of squished to the sides, which is actually really good because then we can like chat.
Be like, how are they doing?
Yeah. Or like you're like making like eyes of the therapist, like the co-treating therapist across the room and like pointing to your patient. They're still breathing.
They can't coordinate that movement. No wonder they can't stand up.
I've never seen them do an utterance that long. Seriously,
yeah. I feel like we get a lot of good out of the chair dancing. Not just the patients, but I feel like we get to see a lot of things and we get to talk about a lot of things.
And catching up with each other.
Planning. Plotting.
Yeah.
Plotting.
What are we
plotting?
What are we doing at 1:00 today?
I know.
Let's decide now.
Let's decide now. And so speaking of plotting, I want to bring up the point that all of us are CIs right now. So that's...
We've been plotting.
So much plotting.
Yeah. And I feel like that's really good too because, so my student, she has done outpatient and acute care. Mm-hmm. But those are really like outpatient. I mean, that's a silo of just PT generally. Mm-hmm. I've worked in a place that had a hand specialist there, so I made sure I talked to him about something. It's because I'm nosy. But generally it's only PT, so you're only seeing PT.
Right.
I don't know about what other your students have done, but
I mean, speech internships in grad school are just formatted differently than your guys's. We do your guys's. My New Jersey is showing. We do generally semester-long placements off campus, and that's preceded by clinical experiences on campus in which you're treating.
Okay.
So my student had generally pediatric experiences. And then I think she said she had done it was like adults, but like young adults with developmental delays, and lots of pragmatic language, no dysphagia, no stroke. And they were working together, her and her CI, with teachers, I think. I don't think there was any PT or OT involvement though. And that girl has done a lot of co-treating just this week alone, due to, talking about scheduling stuff. We have a lot of patients who are sort of all the ones that she was co-treating on have actually discharged to home, which is great. But we've had patients who are rather high level, ambulating, contact
standing, walking,
standing, walking, talking, but rather forgetful, or needs some work on carryover for safety awareness, or needs some fine-tuning on higher level problem solving skills, or really just need to improve their insight, you are not successful. You are not successful with this. What is your game plan? Help us help you discharge plan. And to do that while the patient is working on standing balance with, say occupational therapy is fabulous, because every single time that we do that, they're like, oh, they just stood for 20% longer than they ever normally do. And I'm like, And they also attend way better than when I have them sitting in the wheelchair. True. Just having your 2 feet on the floor and using, your core muscles to make you balance yields such better attention than otherwise. So it's nice to it's nice as a supervisor for your students to see that, because I was taught by some supervisors when I was in grad school who were really big on positioning and making sure that the positioning is good for the patient to be able to do, or student to be able to do what you are trying to get them to do. And I don't know, it just makes me happy that I get to impart that now. So I'm a big nerd. So co-treating is really a really nice benefit for everybody.
I agree. Especially with like some of the more impacted patients, like a lot of the CVAs or people who struggle more with balance
Max
issues.
Assist of 2.
Max Assist of 2.
Max
like,
Assist of 3.
Yeah. It's nice to have someone in there and you can be working together on like skills kind of at the same time, where I'm working on one thing, you're working on another, but it all just kind of overlays into each other. And I kind of pinched your student, Katie, when you were away the one time, because we had a common student, a common patient. Actually, no, the therapist covering you had a patient, and it was a little bit overwhelming because the 4 of us, yes, you know who I'm talking about. So it was me,
so many people.
My student, and then the other OT, and your student, and this poor man who had a CVA, and he barely spoke English, and here we all are, like, surrounding and crowding him, and it was so overwhelming for him. I could just see it on his face, and I think that's something else I learned.
You're like, this needs to stop!
Right, and I feel like that's something else I learned from you, Christina. Like, I can see, after like 12 years, I'm pretty good at reading people, but like I could definitely see the frustration. And my first thought was like, we're giving him too much stimulation and too much feedback. Yeah. So like I backed off, and then my student actually can speak Spanish, so I kind of sent her in. And then the next day, because it was just even 3 people was a lot for him, so I kind of pulled back and let the 2 students. I pulled them aside, and I was like, "You 2 are going to run this session together. Go!" And they did great. Like they took a few minutes and they sat and they planned. They talked about what they were going to work on and like what skills they thought he needed, and they came up with a really good treatment plan. I was pretty impressed by them, I have to say.
I'm really glad that we are able to. I don't know. It's literally just luck that puts 3 students in the building at once, all of different disciplines.
What are the chances?
Yeah.
I don't think I've ever seen it before.
No,
I don't think it's happened since I started working.
I don't think it's happened since I've been here.
Really?
Either. I mean, we've had 2 OTs before and like one PT, and I mean,
or a couple speeches.
But to have 3 concurrently, I don't think has ever happened.
It's a perfect storm.
It is.
I look forward to the next couple weeks of making them.
Yes, because in case
plot.
so. We'll just tell the listeners, like, we've been plotting to have them all co-treat in, like, a just fantastic meeting of disciplines on one patient. We're kind of scheming, and I do feel bad. We're pulling
I'm stealing patients in order to make this perfect.
Is that what happened?
Yes.
I didn't realize that.
Yes.
And I told the other therapist, I said, if you don't see him on your schedule on Monday, it's because I took him. But it's for the greater good.
He's such a perfect, like, student patient. Like, he's, like, textbook on so many things.
Yeah. But also, like, kind of quirky.
Quirky.
And kind of not.
Yeah.
You know what I mean?
Yeah.
And he really likes his bed a little too much. So it's a very good behavior management practice
and then,
for them.
Time management, behavior management. He's so deconditioned. He needs like some straight up strengthening.
Strengthening.
But he's gonna, from what I've seen, will respond well to treatment, which is something that I feel it's so important to have the students see, like, look, what you're doing is making a difference. What we are all doing collaboratively is going to get him from this point to a point that you wouldn't even expect him to reach.
I don't think he expects it either, but it'll be a good day.
Great. No. I've been, like I said, I've been watching her, and she's like, I just hear over and over again, no, you don't want to, I know you want to lay down, but it's really not good for you. We can just sit up for a few more minutes. We can just sit up. Let's just sit here and get your breath. 5 more minutes.
Your heart, your lungs, your digestion.
Oh my.
Seriously.
Lions and tigers
Every
and bears.
day you spend in bed, it's going to take 3 more days for you to get that strength back. Do you really want to crawl back in bed?
Sometimes he says yes.
That's something that is always a good student lesson, is don't ask questions
that you don't want the answer
that you don't want the no answer to. Don't
It
do
is not, do you want to go to therapy? It's, all right, we're going to therapy.
Yep.
Come on.
Let's go.
Let's go.
We have one lady now, and I'll say to her, I learned my lesson, because I would say to her, okay, are you ready? And she'd just look at me, and she's like, Nicole, don't ask me that.
That's what she says.
She's like, Nicole, don't ask me that. I'm not ready. I'll do it, but I'm never going to be ready.
Sometimes I'll say, I will ask patients. I mean, don't ask questions you don't want the no answer to, but like, are you hungry is the thing I have to know. So I'll say, are you hungry? How's your appetite? And they'll say it's bad. And I'll say, are you going to fake it anyway? And most of the time they say yes. So I do need to know that.
Yeah,
I do. There's a lot of no answers. It's very difficult when your metabolism is totally out of whack and your food looks funny and all that type of thing. Yeah, man. But in any case, the other thing I was thinking about too with like having the students co-treat is that I think that it'll be that's a really great thing to talk about in an interview when you're looking for your first job. That's not something that I had as a graduate student.
No.
I observed PT and OT in my second externship. My first externship, I, in hindsight, realized I don't think that my supervisor had a great working relationship with most other people in the building.
Oh, gosh.
So I probably got gypped out of some experiences that would have been beneficial that way. But, the second internship made up for it. But just to be able to say that and to say with confidence, yes, I know how to collaborate. I know how to communicate with other professionals. I know how to deal with scheduling issues. Whenever those come up, I always think out loud. With my student, they're with me, and I'm like, okay, well, that's not going to work. This isn't going to work. We'll try these 2 things. You keep treating them. I'll be back in a couple minutes, but this is what I'm doing.
Yeah.
So that way she can kind of hear what that thought process is. Because I did struggle. Like when I first started working, I definitely struggled with time management. In terms of figuring out when I'm going to be able to get my patients. And I probably spent a lot of later afternoons.
Oh my gosh, yes.
And
like 10-hour days.
Then probably would have been necessary if I had just been smarter. I don't know.
It's a learning curve.
Looking back, it's like, what were you doing, girl?
You know what? Even now, though, like I said, some days I'm just like, I don't quite know how this is all going to work because it's 10:30 and everyone's still in bed or in the bathroom or in the shower, and I'm just like, and she's looking at me like, what do we do? And I'm like,
I don't even
know. Let's keep going down the list and
see what happens.
One day she was like, I'm just gonna go and come back with somebody, and I was like, you do that.
Good luck.
Good luck.
I think though that's where having an experience as a student co-treating can help you with that, because I mean, when I had never co-treated before, so when I first started working, I saw everybody kind of doing it, and I knew Janine did, my clinical fellowship supervisor who was mentoring me at the time, still does, honestly, just from afar. But I didn't know how to say, hey, can we co-treat? I didn't even have a great, I had to learn what that really meant. Honestly, which seems a little silly now to say, but it's true. And now it's like, oh my God, the benefits are there. And it also, helps you keep your own head screwed on straight. So that way you're not treating until your 9th hour of being in the building.
Which
Can happen, but hasn't happened Doesn't happen very
Yeah,
much.
no. I really think that having someone else there with you allows you to push the patients a little bit more than you'd be able to do by yourself, you know,
Safely, too, yeah.
safely, because you have an extra set of hands, but also you have like an extra brain who's helping like plan and plot and like come up with new challenges. Yeah.
And the eyes from a different angle. Like, just to see somebody doing something from across the room, and then I'm like, that's it.
I need to do that for this person.
And I feel like that happens in the gym too with like people who aren't even co-treating. Like I know that I'll have other therapists.
Some other exercises or something.
Oh, I love stealing exercises.
I love stealing. Yes. Like how much do you learn by stealing other people's exercises and just watching other therapists treat is huge. Like I feel like that's just such a learning experience in itself. And across disciplines, I mean, I've stolen ideas from OTs and PTs, but I feel like our department allows for that. It's hard for you because you're like off by yourself.
I mean, I do that a lot. I mean, positioning is probably the biggest thing that applies.
Like
feeding. Positioning for feeding is sometimes, for certain people, it's a bigger issue than their actual physiological issues. Yeah.
I agree.
It really is half the battle. And to, you know, like just spy on an OT session or, you know, when I'm in the dining room and, you know, I see Katie walk in and I'm like, yes, all right. So, well, because I get an opportunity to see how the patient is generalizing.
True.
Also, because I will always communicate the cues and but I'll hang back. I'll hang back and see what the patient is actually doing when the person that they associate with good eating behavior
isn't around.
Yeah. Because I can't tell you how often I will, you know, spy on somebody eating and they will yes me to death and use their strategies when I'm with them. And as soon as, you know, I might see them from afar. They're doing whatever they want. As soon as I get in their eye shot, they're like, oh, okay, gotta go. Small sip. Okay, yeah, small sip. Okay. Oh my gosh.
Chin tuck.
She's watching.
Small bite. Wash it down.
It's like, oh my gosh. I have to fix what I'm doing. So to be able to almost kind of hand off that angel on the shoulder kind of aspect of having the speech therapist, the good behavior, you know, the person that makes you have your good behavior in front of you is very helpful. Not that they don't behave for you, but you know,
but sometimes they don't.
But sometimes they don't, and it's different.
It's like how you behave when like your moms are. I never changed my behavior when you weren't around, Mom. If you're listening, like I was always perfectly well behaved and followed the rules. Totally.
Yeah, we're just competitive with our meals. In the household. Something about being busy or Irish. I don't know. Or both.
I think that's a therapist thing, though, because I remember in school, we would eat so fast, and I can't stop.
Oh, yeah.
Like,
definitely.
And so we all, like, you know, for people who don't know, we all eat lunch together, too, which I think is
off
great. Off of a high-low mat. We all sit around the high-low mat and we eat
civilized.
Together. We put a sheet down.
There's a sheet over it.
We put a sheet down.
There's purple wipes.
But we all, like, we still all eat so fast.
Yeah.
I know.
Which gives us a lot of time to, like, sit around and talk afterwards. And I feel like that's kind of relaxing, too. Like, we get, like, the business
so
side
necessary.
of the way.
Because depending upon what my caseload is like, sometimes that is the only conversation of the day that I didn't have to think really hard to have. Like, it's probably the best way to put it.
Yeah.
And the mean way to put it is that it's the first conversation I've had all day with people who are making any sense.
And people who actually want to talk to you.
Yeah.
Sometimes.
I've been pretty. It hasn't been that bad lately. It's been pretty good.
No, I haven't. I haven't had any chronic refusers yet, which I want my student to have one because that's another important.
She can come over onto my caseload.
I had one, and then he went out to the hospital, and I was disappointed for multiple reasons.
The biggest refusal in the world.
Yeah, that is the ultimate refusal. Not in the building anymore.
Gone.
Peace out. But she did get to see some behavior management magic because she, you know, went down the hall to get him. She came back. She said, "He's refusing." I said, "Okay."
Oh no.
Stood up.
No, he's not.
Spoke with the patient for roughly 92 seconds.
Yeah.
Found his price. Turns out his price was the fact that he's on a food restriction but didn't eat his soup. So I was like, "Oh, I'll give you water." Didn't even have to pull anything fancy. Just did a good old 4 ounce for 4 ounce trade. And it was all I needed to do. And hopefully she'll have that in her toolbox in the future. I don't know. We'll see what happens.
There's like a list of like things you have to go through when patients say no.
Yeah.
Why are
the
you
hierarchy?
Why are you saying no? What can I get for you? What can I do for you? I'll put you back in bed afterwards since you've been out of bed for 4 hours. Like there's a list.
Yeah.
And only once you've gotten to the bottom of that list, you leave that room and say,
That
better luck
is
next time.
sometimes that is something that can be kind of rough. Like just speaking about, like interdisciplinary issues and like working with people is if I have a patient who I convince to get up out of bed, because I hate treating people in the bed. I do it, and I definitely do it more than you guys do.
Oh, yeah.
But it happens, and but sometimes I'll get a patient. I'll be like, oh, you can get back to bed afterwards, and like an idiot, I didn't check the schedule, and sure enough, they have.
And then they're so mad.
They're really mad.
They're so mad.
I know.
And
It's
then
really
I'm like,
bad.
who is she? And they're like, the one with the questions. I'm like, oh, the one with the questions is going to hear
The
it.
one with the hair and the questions and the glasses. I try to keep a sense of like who at least has therapy in like the morning or the evening in the gym, or evening, the morning or the afternoon in the gym.
We have that late session going on.
Yeah, evening sometimes.
We have our late crew.
And order. See, if I'm there to witness the late crew, something horrible has happened.
Right?
Because
That's
Katie
definitely...
and I are definitely holding down the morning.
You
crew.
will not see me past 3:30.
No.
If you do, you should be serious.
Yeah, I'm
Something
concerned.
terrible
Like,
has happened.
And it's funny because like there's definitely waves of people coming in. Like in the afternoon, there's only a certain number of us there after 3:30. And
Well,
if I
the
see
morning is
anyone
the
else,
same.
I get nervous. I'm like, whoa.
I guess not everybody does like staggered like scheduling or whatever, like staggered hours like we do. I thought that was...
It makes so much sense.
I thought that was commonplace and that everybody did it, but I found like even in some buildings, like in other rehabs, like for our hospital, that is not necessarily the case.
What, like everyone comes 8 to 4?
Pretty much, yeah.
Yeah, some of the other...
And that just is like, that is a really great way to run into some scheduling issues.
yeah.
And I'm curious as to whether or not they actually have those problems, or maybe they don't, or...
and that's what I've learned
Yeah.
is that by coming in like later, by like staggering my day back. First of all, let's put the kids on the bus, so
Right, which is
amen
important.
for that. But then also, like by the time I get there,
Attending
usually
school,
attending
important.
school important. But generally, by the time I get there, like people are up. OTs have done their ADLs. Like I can imagine how frustrating it would be if you're trying to get someone dressed and the therapist like comes in and snags them out. Like, and the patients hate that. They hate when they're not dressed and we bring them down to the gym.
Well,
So,
of course.
I mean, I do it, but ones in sweats, come on down. But no, I found that people, it helps with the scheduling because I know people are more free towards the afternoon.
Yeah.
Because they've already seen you, and I'm like, all right, I got
There's
a little...
very few dialysis patients that time of day.
Oh, yeah, that's rough.
Dialysis is really rough
Dialysis
right
is
now.
really
and
rough.
And
Very difficult.
And that's
that-
rough across the board because that hits, talk about scheduling problems, that hits all of...
as we all take a sip. Maybe I should start doing, like, actually, no, this is giving me a treatment idea. Interdisciplinary ideas happening in real time. I haven't in the past done any, I'll do, a renal diet, carryover in education. I'll use that for stimuli.
Yeah.
I'll use CHF education as stimuli, but I can do like check your feet.
Oh my God, if you could get people to check their feet more often, like, I feel like that's something we need to make like a normal thing. I get like...
I need to talk to the wound nurse
I get
and
that
see
feet can
who
be...
I should be targeting with
can
that.
be
I'm going to start
gross.
doing that.
Like, I get it. Feet don't bother me because
bothers
they
me.
don't bother me at all. Feet don't bother me at all. Like, that's what I'm known for.
That's why I'm a speech therapist.
No, I can't handle
Nicole
people chewing
touches everyone's
food.
feet.
I do touch everyone's feet, and I make my students do it too because you're standing on them. Like, I want to know what you're standing on. Like, what is my support? Like, what kind of foundation does this house have? Like, I need to know.
No,
I need
that
to know
makes
what you're going to be
sense.
standing on. Like, your toenails digging into your toes? Because that's a problem, and I want to know. But,
I hate this conversation.
I'm sorry.
But it's so necessary.
It's so necessary.
I know, but this is why I'm a speech therapist. This is great. I'm so glad
But if
you
you
guys
could,
exist.
I just feel like maybe if we can make it culturally more normal to
look at your feet.
to look at your
check
feet
them.
and check
Yeah.
your feet, and that might be good.
Or ask
you
for
can
help.
build that into
too,
like
though.
ADLs.
I
Like
really do,
check your
though.
feet. Yeah, I know you
Because
do.
I always check their feet and I'm like, look, is that new? If there's like an area of redness and they're like, oh, I don't know. well, that's your foot. It's connected to your body. Maybe you should be a little more in touch with what's going on there.
Yeah.
Because nobody wants to lose a foot, which is like the dramatic side of it, but it's a reality.
It's a reality.
Like, you see it. You see
all the
it
time.
All the time.
All the time.
At any given moment in our building, I would say more than one person
With a foot wound.
with a recent
yes
loss of some
like a
part of that.
Yes.
Yeah.
Which leads to the forefoot, which leads to the
the-
whole, like
A little nibble.
that's you see these people, you see a little wound on the tip of their toe, and you're like, oh, I know where this is going.
That's it. I'm gonna start doing like check your feet education. I'm
See?
gonna have to make a whole list of
teamwork.
Like, things.
Teamwork.
Yeah.
You're putting your socks on. Take a look.
Take a look at your feet.
Take a gander.
You know.
Do we have? We should and like mirrors. We need to give people mirrors.
I have a little mirror, like
Yeah,
one of the
there
little
is
foot
one.
mirrors. There's one floating around. I know I have one with my stuff.
No, but we need to tell people to have one in their house.
We need one with a longer, like
like a handle.
we need like
for
a
your
long
friends.
handled foot mirror thing, in the same way they have long handled sponges.
Well, I'm saying like with like that's almost something that could go in the hip kit.
Totally.
You know, because those people aren't bending over.
Real time problem solving, interdisciplinary work
Super
happening
cool
right here.
Saturday night.
Oh yeah, I didn't mention that these girls gave up their Saturday nights to do this, like
talk about feet.
To talk about feet.
Oh no.
And mirrors.
You heard it. Feet, mirrors, students.
With
You
that
heard it here
note, I'm
first.
gonna get another one of these things out of the fridge. Does anybody want anything?
No, I'm good right now. So, yeah, and I don't know how you guys do oral care stuff. Like you got
fine. I
see,
love
no, give me the smelliest feet, but please don't make me look in someone's mouth.
No, it's
Which
fine.
I know is just as important. And I try to check, like when I'm talking to my patients, if they have like terrible oral care,
Yeah.
I then try to refer to you guys and just be like, hey, can someone please bring that up that they need to work on? Like
That's
cleaning
been.
their mouth.
I invested a lot of.
I learned how to use that suction toothbrush.
Yeah,
On
it's-
purpose.
All you need
Because
to do is
I-
be competent in it.
Yeah.
That's the rule for using
That
that is
thing
be
is
competent
amazing.
in it.
I
So
love the
anybody
suction
that ever
toothbrush.
wants to know, like I love training people on
Yeah.
that thing because it's so freaking easy.
PTs, learn how to use the suction toothbrush because
It will make your life
it
more
will make
pleasant.
your life more pleasant. It will change your life. And you can do it standing up sometimes or seated at the edge of the bed for
Yeah.
seated balance. It's really practical and it makes your patients feel better and it makes them more compliant. Like that whole like building bridges and getting your patients to work with you. Sometimes you just
If you
have to
feel
be
good,
nice
you're gonna
to-
work harder.
Right.
Yeah.
Sometimes you have to be nice to people.
No, I mean
Lots of times, no, you always have to be nice to people when you're in therapy. Like, let's not
Sometimes you have to be really, really, really nice. People
But-
make you work harder than others.
Yeah.
No, but oral care is good. Oral care, and the other thing though too is having you guys like report to me on that is really, really helpful because I don't, I see the patient maybe during their meal right after they've gotten AM
Yeah,
oral
morning
care,
care.
and I don't hearing report from other therapists about how the patient is actually leaving their room, going down to the gym, which is basically public. Like
Yeah.
you're in public
It's
when you're in the
effectively
gym.
public,
It's
yeah.
effectively
It's
public.
effectively
You
public.
got to treat it the same way. Hear what's going on there kind of allows me to see where I need to, in service and make sure that we're elevating that we're improving constantly, elevating the state of our friends' mouths.
Takeaway from working with a team of professionals, interdisciplinary. What do you think, Christina?
I consider myself very lucky. I've the internships that I've had and the people that I've spoken with have indicated to me that what we have isn't necessarily normal, even for the sniff setting. And I hope that we can even do more of it and keep getting better. And I think we have good, we have everybody's mind and heart and clinical skill base is all in the right spot for that. And we're lucky.
Katie?
Hashtag blessed. Yeah.
Thanks.
I mean, as still technically a new grad, it has made the world of difference in terms of like my comfort level, my knowledge level, and what is that? Like, you're greater than the sum of your parts. Like, together we can do some really, like, when you see somebody who was so debilitated and they are walking out of the building because of something that you and, like, the other professionals have done. That's like the moment where you're like, oh, I could cry.
And it bonds
so
you.
Happy
It
right
bonds
now.
you as a team.
Yeah, it does.
Yeah.
Look what we did.
Yeah.
It's true. Yeah, I like I said, I'm sold on it. I love it. I love the co-treating. I love our setting. I love our department. I'm not just saying that to be nice. Like it's really one of the best
Also,
places I've
Sue,
worked.
you're welcome for not cursing.
Thank you so much for listening. Thank you again to Katie and Christina for giving up their Saturday to hang out with me and talk about therapy. And thank you for listening to the State of the Sniff.
Hit me! Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.